As people trickle in, hello and welcome to the American Society for Stereotactic and Functional Neurosurgery webinar series. Today we'll continue the third part of this series, which really is about topics around refractory epilepsy and epilepsy surgery. And today specifically we'll be focusing on topics surrounding neuromodulation for refractory epilepsy. I'm delighted to introduce our moderator, Dr. Arjun Khanna, who is an assistant professor at UC San Diego and another one of our rising stars in functional neurosurgery. Dr. Khanna, thanks so much for being here.
Cool. Thanks, Sharona, and thanks for everybody. Thanks everybody for joining. Really looking forward to today's talks and discussion. We have three incredible speakers today who just flew through all of their slides, and we have a lot of ground to cover and interesting stuff to talk about. So we'll dive right in. Um, our first speaker today is going to be Dr. Robert Gross, who's the chair of the Department of Neurosurgery at Robert Wood Johnson Medical School and New Jersey Medical School at Rutgers, where he also serves as the Rutgers Professor of Neurosurgery and Senior Vice President of Neurosurgical Services at RWJ Barnabas Health. He trained at Albert Einstein Montefiore, followed by fellowships at the University of Toronto and Yale, and had a long and incredibly productive career at Emory, spanning over 2 decades, where he directed the Division of Stereotactic and Functional Neurosurgery and co-founded the Emory Neuromodulation and Technology Innovation Center. He's a past president of the ASSFN, and his work spans the gambit from closed-loop neuromodulation, which will be the focus of today, but also a lot of work in surgery for stereotactic laser ablations for epilepsy, DBS for movement and psych disorders. So we have the pleasure of hearing from him today about neurosurgical considerations when using DBS or RNS for neuromodulation. And so with that, I'll turn it over to Dr. Gross.
Thanks, Arjun. Thanks, Sharona, for organizing this. It's always a pleasure to share the podium with these two fantastic neurologists. I feel like a neurosurgeon sandwich. So I will run through why briefly, but my neurology colleagues will give you a lot more on that. We'll talk about which targets and where to put the electrodes and how to go about it, all in approximately 15 minutes, probably go to 20. This is, I borrow this slide from one of my colleagues up here in New Jersey, Eric Geller, who's been involved in neuromodulation for a quarter of a century himself. And I really like this formulation where VNS really gets at the roots of the neurons that function to cause seizures. Whereas if you go all the way up to the out of the branches, you get to resections and ablations. And neuromodulation really involves this whole area that's connecting all of these leaves together. So it's a network disorder, and of course, we have different ways to go about that with VNS, DBS, and RNS. So this is most certainly a network disorder. Seizures are a network disorder, and so the treatment is involving treating that network. And this is just a short list of many of the targets in the brain that connect all of those cortical areas together. And every one of them you will recognize as areas that have come under stimulation or have been proposed for stimulation. You'll see this slide from Dr. Fisher's study with Ana Luisa Velasco. A nice review going over some of those targets. So we have lots of different targets, and I like to break it down like this. If you're dealing with neocortical area, basically any focal epilepsy is an area that you could stimulate neocortically. And of course, with neocortical, we're talking about RNS, but not exclusively. You'll hear from Dr. Lundstrom about techniques of using neurostimulation on cortical areas involving different devices than RNS. If you're in the limbic circuitry, we have approved hippocampal stimulation and ANT, and I put pulvinar here because part of the pulvinar, as you'll see both from briefly with me and with Dr. Fisher and with Dr. Lundstrom, is limbic in its network location. When you're talking about motor circuitry, These are all investigational. Centromedian nucleus, which has been studied for close to half a century, beginning with the Velascos, is not an approved target, but is something that we use very commonly these days. STN is something that's been studied for a number of years, beginning with Benabid. And VIM is a target that some of us are beginning to think about as a natural target for addressing motor seizures. Parietal occipital, we get into the circuitry that out more laterally, pulvinar can access. And I put lateral geniculate nucleus here because there's been a single case report of LGN used for occipital seizures from my friend Osvaldo Filavela down in Brazil. And generalized seizures, we really only have the one target outside of VNS for that, and that's CM. To advance. So Doctors Fisher and Lundstrom will spend a good deal of time talking about how you choose these targets from a neurological point of view. When I like this little tree, which Dr. Fisher was involved in making as well, practical considerations in epilepsy neurostimulation, and basically says who you're going to do neuromodulation on. If you have patients that have greater than 2 foci or are poorly localized, then we're into the neuromodulation zone, whereas we like to reserve and promote resective and ablative surgery for people that have 1 or even 2 foci, except in the situation where you may have the desire for prolonged recording for one reason or another. And that's when we get into RNS. Yes, DBS does have recording capabilities, but the utility of them has not been really well demonstrated as compared to RNS. So that's one of the ways in which we choose that. And there are a number of different considerations that will lean towards RNS versus DBS. First of all, your neurologist. So if your neurologist wants long-term ECOG, then then you're looking at RNS. And if there's anything that epileptologists love, and that is to get EEGs and ECOG. So there really is a strong, in my experience, favoring by my neurological colleagues for RNS over DBS. But if the patient can't do daily uploading, or the family can't, then RNS is really not feasible, and we're looking at DBS and certain other considerations. And then there's the hardware itself. If patient likes the idea of cranial and or doesn't like the idea of the neck wire or a pulse generator in their chest, then we're looking at RNS. And then there are some patients that don't like the idea of a cranial implanted stimulator, and they don't mind a neck wire or IPG, and we're looking at DBS. If you're planning on implanting 1 to 2 leads, then you could use RNS or you can use DBS. But if we're doing multi-target stimulation, as some of us have been doing, you're looking at 3 or 4 leads, and really DBS, and in particular, only one manufacturer offers that capability. Then there's ideas that people have about contingent stimulation and conic stimulation. If you think contingent stimulation is beneficial or less toxic, then that's going to lean you towards RNS. But if you recognize that the results clinically are the same regardless of that idea, then we're looking at RNS or DBS. And then we have true believers in one system or the other, and that's going to weigh you in one direction or another. All right, now I'm going to turn to the surgical considerations, and we'll start with ANT as a nucleus. This is a sagittal view, and I have the ANT marked out here, and here's the mammillothalamic tract coming up. And when we did the Sante study, as you'll hear from Dr. Fisher, we couldn't even see the mammillothalamic tract, and we didn't appreciate any difference in the ANT nucleus from front to back. And so we targeted just so long as the electrodes got into ANT. But in this subsequent study that was done in Europe, where they got approval for this approximately a decade before we even did, based on the very same study, Bob Fisher's study, they found that when 83%, that in those patients that had localization posterior to the mammillothalamic tract, 83% of those implanted were non-responders, whereas when it was anterior to the mammillothalamic tract, 74% were responders. And we replicated this in the Sante series, and there's a few other studies that show exactly the same thing. And so for that reason, our surgical target today is the mammillothalamic tract with this anterior inclination. And then that positions the stimulation in the ANT. And we really don't know if it's mammillothalamic tract that's conveying the effects, but we do end up stimulating somewhere at or above the mammillothalamic tract. And we do that with a transventricular trajectory. And why do we do that? We do that because that is the most natural way that we thought about when entering the study. Basically taking the ideas that we had from DBS for movement disorders as a very safe trajectory. And there are considerations in the veins that surround the ANT structure as it goes from ventricular into the thalamus. And there's a surgical window which is between the thalamostriate and the superior choroidal vein. And that window is present on almost all sides, but not every single one. We look for the space between those goalposts. That's what it looks like. But I like to encourage people not to overly fear the veins. And even there are times when you think you're not going to be able to get through there. But if you remember that in Sante, where we didn't even do contrast studies when we were implanting, so we didn't see the veins, only 8% of patients had IVH and all of them were asymptomatic. So that's 220 sides. So we really shouldn't overly fear the veins. And the reason probably is because the veins are in the ventricle and they move, so long as you use a blunt cannula. If you go through with a microelectrode, you might have a different outcome. That's why we do transventricular trajectories. And in fact, we found out that, again, from the European studies where they were actually very disinclined to go transventricularly, and many of them took an extraventricular approach from a frontal entry. And the success rate for placing at least one contact in ANT bilaterally was significantly lower when you went extraventricularly, because it's easy to deflect and completely miss ANT, whereas when you're coming down straight on, you're not going to miss it. So we strongly encourage people to take a transventricular approach. Now, there is an alternative extraventricular approach from what the Europeans did, and that's what's been promoted by my colleagues at Mayo Clinic, where they come in from a parietal aspect along this axis over here, and at the top. You see the mammillothalamic tract here, and you can come in like that. Personally, I don't favor this. I've done this in 2 cases, and in one case, what was located well in this region initially, about a year or 2 later, turned out to break out of the top and was no longer positioned very well. But it's a matter of personal preference. It is another way to go about it. Now, any implantation technique that you choose is good, just so long as you know how to use it. The implantation techniques all but don't matter. You can use rigid frames, robotic assistants, disposable platforms, MRI platforms, disposable MRI platforms. So long as you do it well, it doesn't matter what you use, so long as you always use intraoperative imaging to verify where the location is. Fiducials is the translation of fiducials is trust. But we trust, but we always verify because these leads can become deflected and go into the wrong location. And this is just one example of a case of mine where we could see that we had a couple of millimeter deflection off of the chosen trajectory. And if you see it right away, then you can fix it right away and make sure that patient never leaves the operating room with a poorly localized lead. Now, one way you can do that is by using the ClearPoint or other MRI platforms such that you can see the MRI imaging and not rely on a co-registration with a CT scan. And I have done a number of ANTs using ClearPoint. However, although it is arguably the most precise because what you see is what you get, It is a very time-consuming procedure, and I think actually for ANT, it's overkill. The size of the target is big enough that a 1 or 2 millimeter deviation that might or error that might happen from co-registration error is generally tolerable. But you must use some form of 3D verification. So the key surgical considerations for targeting ANT are preoperative MRI sequences to be able to see the mammillothalamic tract, exclusively direct targeting, trajectory and approach, frontal transventricular versus extraventricular. The cannula length, we always use a 2-target cannula, again, because it's blunt and therefore will not harm the veins, and it is also much less prone to deflection than microelectrode cannulas. We visualize and avoid the venous structures, but remember, don't be too afraid of them. All these cases are performed under general anesthesia because there's no reason not to, and these patients can have seizures. And MER, microelectrode recording, is essentially of no value, or rather, the value has never been demonstrated. And sorry, I had a little difficulty with advancing these slides. Okay, now turning briefly to Centromedian, and the case for Centromedian will be described by my collaborators in this, but just where is CM? This is the centromedian nucleus below the medial dorsal nucleus and just medial to these ventral basal nuclei, so VPL, you can see here, and this is a source of some of the side effects that you get from this. If you're too far lateral, then patients will have sensory stimulation when you activate. If you're too far medial, you're not in CM and you're in parafascicular. And you actually can see this pretty well nowadays. This is MP2 range imaging. You get the same thing with white matter null imaging. And we don't see the CM, but we see the other structures surrounding it. The pulvinar is very well seen, medial dorsal, and then that places CM right in this little spot right there. There's actually a very good sequence for seeing this as well. I'll show you in just a second. But I put this up to show you that when you actually position into CM, there's lots of different regions that your electrodes can have access to. There is some controversy about whether CM is the real target or whether the target is somewhere else. I heard it stated just recently in a conference that CM is not the target. That we don't have information to say that. At this point, we consider CM to be the target, but if you get benefits from electrodes that go elsewhere, that is, we are open to that possibility. This is from my paper that I published a few years ago, and it does show microelectrode recording. So why do we have microelectrode recording when I say that it's not useful? The only reason I did microelectrode recording was because the reviewers insisted upon it. So I did one of them. Here's an imaging sequence with QSM, which came out about 10 or 15 years ago and is commercially available, actually. And QSM is really nice for seeing the pulvinar and thus being able to see the centromedian nucleus, again, very nicely. And you can see that superimposed here. I'm sorry, go back one slide. So you can see the pulvinar right over here and then the CM right up anterior and medial to it. So it's pretty easy to see CM at this point. There's a lot of variability in CM targeting. There could be a role for the ventral basal complex, and this has been appreciated both from epilepsy as well as from Tourette syndrome, where oftentimes when targeting the CM, it's actually the VOI region that ends up being stimulated. But we still aim for CM regardless. This paper is the original Velasco paper showing the location of all of these electrodes. And, you really can end up with electrodes in quite a span. Of course, this was using old techniques. But the point that the Velascos made in their paper was that it's the parvocellular deep part that is actually our target, and anatomy supports that. We nowadays have availability of other techniques for targeting aside from simply anatomical imaging. This is just a slide from the study that is still ongoing on thalamocortical RNS for Lennox-Gastaut, where with Chris Butson's help and Aaron Warren's help, we use various techniques to identify the region that we're using, including connectivity. And in that study, because we only have one, we put two electrodes in on each side, and so we did bilateral craniectomies, but that's not standard. Briefly with pulvinar, I wanted to point out that there are four subnuclei in pulvinar, so you can't just simply say pulvinar stimulation, and they each have different distribution of connectivity. The medial part goes to the limbic circuitry, whereas the lateral part goes more to those parietal and occipital areas. Dr. Fisher is going to show this very shortly, only to point out that we generally take a parieto-occipital approach to the pulvinar when we're putting electrodes. And nowadays, we have new targets that are become available based on putting together the results that come from using stereo EEG and being able to truly study the network of all of our epileptogenic zones, as well as the connectivity. This is from a beautiful paper from Jorge Gonzalez Martinez's group. Far too complicated to get into, but the point being that when we use stereo EEG and use various neurophysiological biomarkers, we can identify both the targets that we know as well as some targets that might be coming down the pike for different epilepsies like motor seizures. And one of the things they observed is when they have a good hodological match between the epilepsy and the target, they got good results, including from Sante, whereas when there's not a hodological match between the epileptogenic zone and the target you're stimulating, the results are less good. Now, we do have a lot of variability in results, and these patients are all difficult. So there are times when we may want to combine targets together. This is a nice study out of Dr. Lundstrom's center, and you can see up here where he looked at ANT and CM together, and ANT did not improve CM. And I encourage you to think very carefully about why you would want to do multiple targets before you do it. We have various reasons to do it. Like, for example, a patient who has straightforward symptomatic generalized epilepsy and drop attacks, we might do CMDBS. But what about when they have prominent GTCs which don't respond as well to CMDBS? Might we use ANT, which has been shown to decrease seizure burden and intensity? So sometimes we may want to do both. Sometimes there are myoclonic features in generalized epilepsy that may or may not respond to CM, so one could consider STN or VIM. And for this purpose, we utilize the one device that's available that can accommodate 4 different leads and allow us to play with that. You can read this paper from a few years ago where we did various combinations of targets. I will say that when you do that, I encourage using a robot. Whenever you're getting into 3 or 4 targets, the robot is probably the best way to do that. Just some examples of these electrodes coming in and what they might look like. And you can actually get 3 nuclei with 2 electrodes on each side. ANT, medial dorsal, I think Dr. Fisher is going to say something about that, and centromedian. In this one, we combined pulvinar and CM from a posterior approach, and so that's reasonably easy to do in terms of positioning. For multi-targeting epilepsy, there's rationale based on multiple targets being involved in seizures. But you have to think about the fact that we don't really know what we're doing in any of the targets, arguably. So you're adding an unknown mechanism to an unknown mechanism. And so the results are going to be somewhat unpredictable. And there's a very large parameter space when you get into multiple electrodes, and then we're getting into multiple frequencies, which you're going to hear about shortly. We call this the curse of dimensionality, when there are so many features that can be programmed that it becomes very difficult to figure out your way forward. And so there'll probably be a role for machine learning optimization and using other network controls. So to conclude, I'll leave you with these few takeaways. We know the most about ANT. Does that mean we should be using it even in non-limbic epilepsies? What's the pretest probability of ANT working in motor seizures despite the results of Sante? So that's one reason why we think about other targets. But we don't know very much about any of the other targets for focal epilepsy. And so this contributes to the complexity of treating non-limbic patients with neuromodulation. CM is very much studied, but to date, despite two randomized controlled trials, we have no demonstration truly of the clinical effectiveness, although you're going to hear about some of the design features that might have compromised those studies. And yet, we still think it works. We have had good results. And we don't have any other options beyond VNS for generalized epilepsy. So that's what we're left with. And this is a stereotactic operation. Some years ago, I was teaching a course with someone who claimed that because we don't really know where the target is, it's not a stereotactic operation. So we should aim for and get the electrodes into the target most likely to be effective and verify it. But all of these are complicated patients. Troubleshooting has to address the curse of dimensionality, trying other frequencies, but you always must include an imaging analysis of electrode location and do this in the context of a multidisciplinary clinic so that we, including my neurology colleagues, can learn together. And with that, I will turn over the podium.
Fantastic. Thank you so much. That was incredible. And I had typed this in to the chat as well. But to all of our attendees, if you have questions that come up along the way, please feel free to type them into the chat. I'll compile them and we'll pose a few to our speakers at the end. But please feel free to do that. Next, we'll have Dr. Robert Fisher. Um, uh, give us his talk. He is a professor of neurology at Stanford with a courtesy appointment in neurosurgery. He earned his MD and PhD in neuroscience from Stanford and has spent his career advancing the science and treatment of epilepsy, including more recently the science of neuromodulation for epilepsy. He has an enormous publication record, but very notably led the Sante study group that established anti-DBS as an effective treatment for refractory epilepsy. He's a past president of the American Epilepsy Society, past editor-in-chief of Epilepsia, and has led international efforts to formalize our modern definitions of epilepsy and classifications thereof. His research focuses on neurostimulation devices and technologies, and he's going to talk to us today about decision making surrounding neuromodulation for epilepsy, particularly with an emphasis on DBS, and how to think about programming these devices in clinic, among other things. So I'll turn it over to Dr. Fisher.
Thanks. I agree with everything that Dr. Gross said, and now I'll just give you the neurologist perspective on it, which actually isn't that different. I don't really have any relevant disclosures. A few years ago, I led some studies. Money went to Stanford. I'll skip over those. These are the 3 approved neurostimulation sites for epilepsy, and many others. I think, particularly Centromedian and hippocampal stimulation are likely to be approved in the near future. At least I hope so, because there's data for them. We were interested in making ANT a target after a certain amount of fear stimulating the mammillary body, just because if there were a hemorrhage there, you could end up with a Wernicke-Korsakoff syndrome. And because ANT is on the circuit of Papes, which goes from hippocampus via the fornix to the mammillary bodies, posterior hypothalamus, mammillothalamic tract, to ANT. As Bob Gross said, the termination of that is our usual target, not because we think the MTT is critical, it's the input, but it usually marks the place of origin of the anterior thalamic radiations, which continue the circuit through the cingulum bundle back to entorhinal cortex and hippocampus. So this loop encompasses mesial temporal lobe and mesial and anterior frontal lobe, which are the most important areas in the brain for mediating seizures. These are the pivotal trial results where down is better, fewer seizures. They were implanted. We then had blinded study for 3 months after implantation. Those of you with an eagle eye will note that there was about a 20% decrease after implantation. The same thing happened in the RNS trial. And people talk about a micro lesion or a placebo effect, and maybe that's true. Or it just could be that nobody goes into a brain surgery trial when they're doing well. So that's a regression to the mean factor. But this bar here is what convinced me that the treatment actually worked. When we turned the placebo patients on to active stimulation, they quickly reached the slow improvement that you saw in the entire group. At 5 years, 18% were seizure-free for more than 6 months and 8% for more than 2 years, which is not, as we used to say in Brooklyn, chopped liver, because these patients were having 20 seizures per month median at the center. So Dr. Gross showed this slide indicating in this case with not an MP rage, but a different type of scan. You can do a STIR scan or any other scan that will show the tract well, that we can pick our target according to the location of the mammillothalamic tract. And that's one of the 3 things I wish I had known when we designed the trial, that anatomy inside the ANT matters. The other is to build up gradually. Don't start right away with 5 volts or 5 milliamps, because you may provoke seizures. It's like drugs. Start them slowly. And I wish we'd monitored sleep, since ANT generates sleep structures. But we kind of got lucky, because even though you can show this affects sleep, it's not really a big clinical problem in most patients. So although ANT is the only target that's currently approved for epilepsy, it's not the only one that works. This is just an example of seizures starting in the lateral temporal neocortex in a patient, spreading to the anterior nucleus, but also spread prominently to pulvinar. So we have taken to paying attention to these nuclei. They're probably not the only nuclei that matter, including the medial dorsal, the pulvinar, the centromedian nucleus of thalamus. You can see that, well, you know already because you're neurosurgeons, that you kind of get the medial dorsal, or dorsomedial if you prefer, nucleus for free, because chances are with an anterior approach, your most distal contact is probably in the dorsomedial nucleus. So we have taken, mostly under Dr. Vivek Butch's guidance at Stanford, to extending the electrode stereo EEG that we're going to put in anyway a little bit farther into thalamus. We don't add any extra electrodes just for thalamic recording, but we extend them so that they record both our desired target and typically sometimes the thalamic nuclei. Our big surprise was the pulvinar. I don't know if any of you remember Rodney Dangerfield, the comedian, but he used to have a line, "I don't get no respect." The pulvinar is the Rodney Dangerfield of thalamic nuclei. It's the biggest nucleus in the thalamus, but we thought, okay, it's probably got something to do with the algorithm, but didn't think about it otherwise. And, in fact, the lateral and inferior pulvinar are connected to the parietal and occipital region, might be relevant for parieto-occipital seizures, but in adults, those are not the 2 most prevalent lobes involved in epilepsy. But the medial nucleus of pulvinar has vast connections to amygdala, to hippocampus, even to frontal lobe. And when we tracked what showed up first in propagation of seizures and what showed up most prominently in a paper that's just been submitted, accepted, I think. The pulvinar was the star of the show. It depends a little bit about where your seizures are. ANT is still very prominent for mesial temporal seizures. But pulvinar also shows prominence in some of those, as well as other more widespread areas. So other nuclei, Burdett used the RNS system in 3 patients and put it in the pulvinar and got a significant reduction here. Up is good, unlike what I showed before. And then there have been several open label trials of centromedian nucleus for generalized and highly multifocal seizures, particularly of the type that you see in the Lennox-Gastaut syndrome. The blinded trial was the Estelle trial by Gallick and senior author Archer in Australia. It just missed significance for seizure counts at p equals 0.08, was significant for EEG changes. But I think those who look at the study carefully think it was just a little too small to pick up significance. But in honesty, there's no proof yet that CM stimulation in a randomized prospective trial or pulvinar or medialis dorsalis are good for epilepsy. We and neurosurgeons do a lot of things that are off-label on the basis of what literature we have. I don't have any treatment evidence for medialis dorsalis, partly because we were getting a fair number of unpleasant side effects from stimulating MD. This paper just came out this year in J Neuroscience, and it shows that there are a fair number of visceral, emotional, and somatosensory negative responses of the patients. Those are the bars in red. We haven't yet played around with stimulation, like maybe low frequency stimulation or different parameters would work without these side effects. There are also some psychiatric side effects of stimulating MD. So let me finish my talk up with a comparison. How do we decide? I mean, I've been going to seizure surgery conferences for about 30 years, and we used to argue about whether to operate or not. Now we're mostly arguing about what type of neuromodulation to do and where to put it. But the positive side of that is that in the old conferences, it was pretty common to say there's nothing we can do to help. That is really unusual now. Almost always we can try some type of neuromodulation. It's unfortunately not curative, but it almost always helps. I feel obliged to indicate the true indication. VNS is for 2 years and older. The other 2 are for 18 years and older. And none of them are on label for generalized onset seizures. So it's probably not totally fair to compare the different modalities in terms of seizure control because they are different populations. DBS and VNS tend to be more multifocal, which is often why we put a DBS in instead of an RNS. But the efficacy in the blinded phase wasn't that different. You can see this is in the first typically few months. And then long term, the median seizure reduction is good. And between 15–20% approximately of the RNS and DBS patients become seizure-free for 6 months or longer. Slightly lower number for VNS, I think. The side effects of VNS are mostly throat, unless you get the rare sleep apnea caused by VNS stimulation. It's just another way of saying what happens in Vegas does not stay in Vegas, at least not always. I hope you will forgive that pun. But even these side effects, if you build up slowly, are not too bad. RNS has implant site infection, site pain, occasionally more seizures, not usually, and you may end up not being at the right place in the seizure focus. In fact, our center often puts in a couple of extra leads which are not hooked up until the company gets a stimulator that can actually do 4 leads, in case we decide that we put them in the wrong place. And DBS, has the infection. It has some paresthesias of the chest because we included in the current loop. Transient depression. Brian may have something more to say about that. I would just say that I don't recommend DBS in ANT for patients who have suicidal ideation, because then transient depression can lead to a permanent bad effect. Transient memory problems, and you can get seizures if you start with too high a voltage. The most serious side effect is, of course, SUDEP, sudden unexpected death in epilepsy. And it appears that all of the neurostimulation methods lower the SUDEP rate substantially over the 7.5 per 1,000 patient years that we typically see in the patients. So even though I did participate, and I think it was along with you, Brian, as well, in the making of that flow chart, I find a table more useful to decide which to use. If they say, don't touch my head, then it's VNS. If the seizure focus or foci are unclear, then it's not RNS, because you've got 2 leads to put over the seizure focus. If the workup is going to be invasive or difficult to localize, I don't like putting my patients through stereo EEG when the outcome of DBS and RNS is really quite similar. So our discussions very often come down to, okay, if we think it's bihippocampal, let's do RNS, but if we think that there's something else happening elsewhere, then we will be more likely to go with DBS or VNS. On the other hand, if you have a well-localized focus, like let's say a cortical dysplasia, I have to think that putting stimulation right on the seizure focus is going to be more effective than stimulating a node on the network. Unproven, but that's what we do. If you want good recording, and RNS is the best long-term recorder that we have, except for being invasive, then RNS is the way to go, because it gives you beautiful tracking of the seizures and enables us sometimes to go back and do a laser resection afterwards. There is some recording from DBS, mostly power spectrum kinds of things. Helps a little, but it's not as good as RNS. For posterior seizure foci, it's not on the circuit of Papes. I'm not that enthusiastic. Untreated severe depression, not mild depression. They want to avoid a visible implant, that's the RNS. If they're an opera singer, I would not give them the vagus nerve stimulator, because it would make them sound like the Godfather every 5 minutes. If there's limited cooperation with programming, not RNS. And then I think for greater efficacy, still RNS and DBS over VNS. There are so many stimulation parameters that could potentially be chosen, and one of the largely untapped areas is trying to record something, figure something out about the characteristics of an individual patient's seizures and tailoring the stimulation to that rather than just dump square waves. Can we predict responders? We can with electrodes in the head now. We can't do it that well non-invasively, although I did have one study with my Beijing collaborators that suggested if you look at connectivity non-invasively with ANT, and it's not very good between the seizure focus and it, then the outcome is not going to be very good either. Can dogs predict seizures? I think cats can predict seizures, they just don't tell you. Why would they care? So these are my conclusions. Neuromodulation still in its infancy, but it's already had a big impact, makes it rare for us to say there's nothing we can try. All the 3 approved modalities have similar efficacies. VNS is less invasive, but paradoxically, it's the only one that patients usually feel and are bothered by. RNS has a good safety profile, but requires localizing the seizure onset site. RNS can chronically record and log seizures. DBS may cause transient memory and mood problems. The circuit of Papes was originally described to mediate memory and mood. In the future, I think we'll have better personalization in terms of the kind of targeting that Dr. Gross talked about, but also I hope seizure characteristics, like what is the frequency of termination of a seizure. I'm spending a lot of my time on non-invasive stimulation. I perhaps shouldn't admit that in a group of neurosurgeons, but transcranial magnetic stimulation, transcranial direct current stimulation, where anecdotally stopping status in some cases, or at least correlating with stopping status in the ICU. And my most recent favorite toy, which is focused ultrasound, are all potentially very useful in terms of future modulation. So my advice, not to you activist neurosurgeons, but to my fellow neurologists who often tolerate 2 or 3 seizures because it's only a couple per month and there aren't any injuries, is to not be complacent, but to try some form of neuromodulation. Choose wisely, but most of all choose. And although that quote could be attributable to Yoda, it was actually from me. So that's my talk.
Fantastic. Thank you so much.
You're welcome.
We will move along, and I see the questions. We'll address questions at the end, just for the sake of time and efficiency. So let's round out with Dr. Brian Lundstrom. He is an associate professor of neurology and biophysics in the Division of Epilepsy at the Mayo Clinic. He earned his MD and PhD in biophysics and neuroscience from the University of Washington, and has expertise in single neuron physiology. He completed an epilepsy fellowship at Mayo, where he leads Mayo's Neuromodulation Clinic and its Brain Adaptation and Stimulation Lab. He's going to talk to us today about decision-making, mostly focused around RNS implantation, including target selection, how we can use data from the device to guide programming and other clinical management decisions. So I'll turn it over to Dr. Lundstrom.
Thank you very much, and really a privilege to speak in such a group with Doctors Gross and Fisher. And I'll talk primarily from the RNS perspective. I have worked with a number of companies, although no personal financial relationships. And I'll just start out by saying what's been said in that there's 3 FDA-approved invasive stimulation approaches, and then a couple of non-invasive, as Bob Fisher was just mentioning, that do show some promise. But I'll focus primarily from the RNS perspective, and I'll start by saying I am a believer that targeting matters. However, when you look at what's published, there are not clear. It's hard to find evidence where there's a notable increase or much better outcomes with one target versus another. So all of these targets that are listed here have been tried. They've all been published, primarily retrospective, and they all show about the same results, which is on the 3 to 6 month time scale, about a 50% reduction of seizure frequency and or responder rate. So maybe it says more what we need to learn about specifics of patients and so forth. The other thing to remember, and I love the point that Dr. Gross made about this infinite parameter space. There are so many things to consider here that don't exist with medications. And one of the primary things, I think, is to remember that stimulation can always worsen seizures. If you don't stimulate enough, that is to say, if your amplitude is 0, it will never make things better, but you can always reach a stimulation amplitude that's too high and cause seizures in anybody, I would say. There's an epilepsy paper here that talks about using stimulation for diagnostic reasons as well as to cause seizures and to treat seizures. So that's discussed there. And then we get to sort of these issues. Well, what matters then? Is it that how much do the targets matter? And by target, it's not just where you put the electrodes, but it's also how you stimulate. So which becomes the plus and the minus, the anode and the cathode, and how does the current go between them? That actually can play a pretty significant role. I'll give a few examples of that. The approach, it's a little bit unclear to what extent the approach matters. But it's definitely clear that the parameters matter. For example, the frequency And people don't mess with pulse width too much in treatment-related cases, although they do more when causing seizures, and certainly clear that matters there. So I think that's very clear. But when you look at the data, as has already been pointed out, between RNS and DBS, it's hard to find a reason to think that there's a difference in efficacy or effectiveness in the real-world situation of outcomes over the long term. The data look pretty similar. I think most neurologists would say that VNS is also helpful, but across the board, it's maybe a notch less effective. But in certain cases, that may not even be true. What certainly is true is that these approaches differ in where you stimulate, whether it's a node of the network or the seizure onset zone itself, and they're different how they stimulate. So the differences certainly exist. The differences in outcomes are maybe less clear. I'll focus on RNS and want to make a few key points. First of all, the RNS is a cranial mounted IPG. It only has 2 leads. It is not rechargeable. So it has a battery life that lasts maybe with the newer battery up in the 8 to 10 year range, but does need to be replaced. And it only has, well, it has 4 bipolar channels. So there's 8 contacts. So the contacts are paired, so 4 bipolar pairs. It can record data for usually it's set for 90-second epochs, and in that case, it's at usual settings. It's about 8 of those, so 12 minutes of data. That's it. Now it monitors all the time, and it does record certain markers all the time, but it's limited to about 12 minutes of data. So you then need to swipe a wand and so forth and have the patient download. We tell patients, depending on how often they have interesting events, anywhere between daily to once or twice a week. And a typical workflow is that the device is turned on immediately, but that's the sensing, not the stimulation. And stimulation is then turned on about a month later after, hopefully, you've recorded a few seizures so that you can optimize the detectors. They're set on a very general sensing protocol initially using line length detectors, and then usually they're switched to bandpass detectors and optimized to the seizure onset later on. The mechanism of RNS is yet not completely worked out, but most people would say that RNS does not work by stopping seizures. It works by reducing the probability of having seizures via some neuroplastic effect. And in some ways, that's why we have this slow optimization of stimulation. When we see RNS patients, this is sort of the workflow we go through. There's an ECOG library that has these typically 90-second epochs if they've been recorded. They come in 4 different flavors. Here you can see all of these are saturations. And what that means is that the amplifier was saturated. For this particular patient, that meant that the patient had a seizure. That's one of the things that we could correlate with the seizures very clearly in this patient. It turns out it differs by who you ask, but RNS is a good seizure counter, I would say, for about 50% of patients. Some people might go a little higher than that, some people a little bit lower. But for some patients, it is very difficult to know to what extent the RNS can be a good seizure counter due to some of these technical constraints of the system. But once you have recorded some data, so for example, this is a seizure. These are all seizures, in fact. The blue means that it was a seizure that was detected. In this case, the black, it was a seizure that was not detected. So you can optimize the detector. You can define the patterns here in stage 2. We then are going to choose minuses and pluses, cathodes and anodes, and then the current, charge density, and so forth to hopefully optimize how it's set up. And when we talk about targeting, certainly after the targeting has been done, that is to say, after the leads are implanted, one of the things we think about quite a bit is how we're going to stimulate between contacts. So one thing that's been talked about is regional coverage. Typically, I would say 3 to 4 centimeters would be the maximum, although people have certainly done more. And there, the idea would be is that you're going to hopefully have an anode on one of these and a cathode on the other, and current will go between the contacts. That would be one idea anyway. The idea being that you can have some sort of regional coverage. Another thing to keep in mind with the RNS device specifically, this is not true for the Medtronic device, but it has a single current source. And what that means is if you're stimulating multiple contacts at one time, if one of those contacts, for example, is in CSF, as was the case in this patient, that means the current will be directed to that contact, and it may be therefore ineffective. So it's a thing to keep in mind. Some of these details can matter. It depends on how the device is set up and so forth. But for the RNS device, all the current that's coming out of the device will be, in effect, shunted to a low impedance contact. So seizures are recorded, and then what we're trying to do is obtain an accurate seizure count. And for a patient, I would say, by the way, for patients with convulsive seizures, or for example, IGE, or idiopathic generalized epilepsy, very often it's a high percentage of patients that for which RNS is a good seizure counter. It's for some of the more focal seizure epilepsies where it's maybe not quite as useful as a seizure counter. But here you can see we're looking at a seizure here that was recorded as a long episode here for 180 seconds, and then a specific seizure here that's detected, for example, here by this B2 detector. And in this patient, interestingly, this patient happened to be on an experimental trial for another drug, which was this patient had probably 12 to 20 seizures a month, so multiple seizures a week, and was seizure-free on this drug. He was able to be on this drug for a short period of time here for about a month and was seizure-free. And so you can see that this is tracking, in this case, interictal epileptiform discharges, and it goes down while he's on that medication. He then started that medication again recently, and so the interictal discharges again go down. So sometimes these interictal discharges, strictly speaking, they're not necessarily interictal epileptiform discharges. They may be what sometimes people call IEA, or interictal epileptiform activity. And the distinction just simply is that sometimes what's detected isn't what we strictly would call epileptiform discharge. It's a sharply contoured waveform, and so there's some uncertainty there, but it does seem to correlate with clinical outcome, at least in some cases. One of the key important advantages of the RNS device is its potential for helping with diagnosis. And probably one of the key situations in which that comes is when we don't know for sure whether the left, the right, neither, or both medial temporal lobes are involved. Now, usually you know if one of them is involved because they're having seizures, and you hopefully feel reasonably certain that one of them is involved, but you may not, in fact, know whether it's coming from both sides. So sometimes what's happened is you have a patient who goes to SEEG, medications are withdrawn, and they have 3 seizures from the left hippocampus and 2 from the right. And then you say, well, we can't do anything because the patient is multifocal. But the challenge there is 2 things. One is that you've reduced medications, and sometimes there are some seizures that may tend to be less frequent or maybe not even happen at all when they are on medications. And the second is typically you have recorded the patient for a relatively short period of time. And so what data like this shows is that it seems like it takes a fair bit of time to get a good sense of whether seizures involve the left, right, or both medial temporal lobes. If you can determine that it involves one, you can potentially treat that side, especially if it's the non-dominant side. I would say if it's 80% or above on that side, something like that, and patients can have very good outcomes. But it takes time to know that, and so that is how the RNS device can be helpful, and potentially other devices coming, like subscalp devices and so forth. As far as programming goes, typically it's increased very slowly with the RNS device, whereas with DBS we typically talk about amplitudes in terms of milliamps. With the RNS device, we typically talk about charge density. The charge density is simply the milliamps times the pulse width divided by the surface area of the contact, so they're directly related to one another. So it's just sort of a metric standard kind of a conversion that needs to be done. But it's typically start low and go slow with the RNS device. So 0.5 is very low. With DBS, for example, we tend to start at 6. And when some of the RNS trials were done looking at thalamus stimulation, there's a little bit of mismatch there between how high you want to start. Because with RNS, you tend to start very low. With DBS, you tend to start higher. So that's one difference between RNS, DBS, and if you do continuous stimulation. So there's data suggesting continuous stimulation of the mesotemporal lobe or neocortical. And we've done a fair bit, certainly of the neocortical. And there we might even start 10 to 20 microcombs per centimeter squared. So quite a bit more than RNS, where we start with 0.5. And these are what you end up at. So mesotemporal lobe tend to be 1 to 3 in the RNS, 2 to 8 microcombs per centimeter squared, a little bit higher in the neocortex oftentimes. Depends where in the neocortex. DBS, I would say 6 to 12 is where you tend to end up. and we might start a little lower than 6 sometimes these days. The other thing to keep in mind is when people talk about how much stimulation people are getting in terms of pulses, what's typically talked about in RNS is therapies. And people often conflate therapies with stimulation pulses, but they're not the same. A therapy, it turns out, is a little bit, has a bit of a unclear definition, but it refers to when something is detected. And when an event is detected, you can get up to 5 bursts. And a burst, depending on how the device is stimulated, could be as much as 10 seconds of stimulation. It typically is much less than that. It typically would be a couple hundred milliseconds. And for each burst, it will have a certain number of pulses, often around 20. So each therapy often very well may have 20 bursts. So anyway, when you get down to it, the number of pulses actually per day with RNS versus DBS is not as different as you might think, but still different. Low frequency versus high frequency. Oftentimes we hear that you definitely need to use one or the other. It doesn't tend to be so clear. We took some RNS patients who didn't do well in high frequency and shifted them to low frequency, and they actually did quite a bit better. With DBS patients, we kind of prospectively looked at them 50% starting with low, 50% starting with high, and about the same number did well with each. In fact, maybe a little bit better a little better results with the low frequency, but very similar. So the idea here is that there are so many things we don't know. I think some patients clearly do better on low frequency than high, and vice versa. We tend to see more side effects with high frequency, sometimes things like depression. So with significant depression, that can be a concern. I always would prefer low frequency if I was really worried about depression, although I totally agree with Dr. Fisher that if there's suicidal ideation, I might avoid ANT stimulation. Comparing across these approaches is very, very difficult. We've tried to do it at our center in the past. There was a slight difference here with chronic subthreshold stimulation, which targets continuous stimulation to the seizure onset zone. There's a new trial starting with a new device coming up this year. May shed some more light on that. When we look here at the right, these 4-lead devices do tend to do a little better than the 2-lead, but there's probably certain biases about when we tend to implant 4-lead versus 2-lead DBS devices versus RNS. For us, we tend to use RNS only for the hippocampus. Unfortunately, in this data here. So there's a lot of biases that go into what device is chosen, unfortunately. There was a recent trial that stopped with RNS for the Nautilus device. It didn't meet its primary endpoint. Probably that was just because the primary endpoint was not ideal, which was an unusual endpoint. The time to second GTC after stimulation was turned on. But with the overall results, it turns out that it's probably quite effective, RNS, 40% freedom from convulsive seizures at 18 months. That, by the way, though, is similar to the recent core VNS results. So this may be a case where RNS of CM for IgE and VNS for patients with primarily convulsive seizures or a generalized epilepsy with convulsive seizures have similar results. But of course, no head-to-head comparisons, hard to know for sure. With device imaging safety, there are a number of things to be careful of. When you do a 4-lead device, for example, you're making it probably impossible, but very difficult to get a subsequent MRI. It depends on exactly where those leads are located and which institution you might be trying to get the MRI at. So it's a little bit tricky. With an RNS, it is approved for 1.5 MRI, but of course, just pay attention to which side you're implanting on. Implant that on the opposite side to whichever side of the brain you might look at. And then, of course, when you are getting imaging done, there's things that need to be paid attention to. Patients need to know this. This actually is an unfortunate event where somebody had an IPG implanted in the belly. It was not appropriately accounted for, and that hemorrhage was the result. And then finally, we have looked at safety for both DBS and RNS in kids and adults. It appears to be overall very safe. No clear differences between pediatric and adult patients. This is down to age of 4 years. The only potential caveat to that was in kids, you do have to worry about a potential bowstringing effect. Although, honestly, this side effect happened more in some patients that had a larger extension from some previous hardware that is not so often used now. But one thing to maybe pay attention to if you're implanting kids. And then finally, thank you very much. If you, there is a stimulation course that deals with some of this invasive and non-invasive data and some hands-on coming up at Mayo in September. Thanks.
Fantastic. Thanks to all of our speakers. Again, that was a really great overview of a fast and vastly evolving dynamic field that's been really exciting to engage with. We are over time, but if our speakers especially don't mind, maybe we can take a few minutes for some questions that popped up in the chat. First, we have a question about lead selection for DBS, in particular for ANT targeting, or what we can really generalize to specific lead selection in general. Whether you tend to use a narrow space leads or like a 0.5 lead spacing or 1.5, and how do you make that decision for which target?
Question was in the chat directed to me. It might be better for Dr. Gross, but in Sante, all we had was 3387, which was 1.5 spacing, and we only got one or two contacts in ANT. So I think the 0.5 millimeter spacing is better to hit your target.
Yeah, almost
Sorry, go ahead.
invariably, if your targets are small, I mean, 338 in the parlance of Medtronic, a 3389 is still going to be bigger than your target. So the only times that we use a longer spacing, and even now the Boston Scientific has an extra long spacing, is when we're trying to hit two targets with one electrode. So showed, for example, the medial dorsal, which we had a biomarker reason to try. It didn't work, but you can get medial dorsal and ANT. You can get CM and pulvinar through with a longer electrode. So that's the only time I use a longer electrode at this time.
I'll follow up with a couple of additional questions. When you use narrow spaced leads like a 0.5 millimeter space leads, and you have multiple contacts in your presumed nucleus as like based on imaging, how do you begin to program those patients? Do you tend to choose like one contact that you feel is most squarely in the nucleus, or do you just turn on all of them that seem to be that seem to be inside?
I think that's going to depend upon whether you ask the Stanford neurologist or the Mayo Clinic neurologist.
Luckily, we have both.
Yeah, but we won't be able to tell you which is better. We pick the lead that we think is best positioned and make it the cathode and make the case the anode. If they get chest paresthesias, we may go bipolar just to take the chest out of the loop. When I started, I said, why don't we do contact 0 and 3 and just take the whole damn nucleus in? But modeling showed that you had a little current flow around each of the two electrodes, and you weren't really getting much current in the middle of ANT then.
Yeah, what we've tended to do is I do agree that using a referential montage does seem to give you a little broader and straightforward coverage. We've often tended to at least just do two cathodes with the idea of just trying to maximize the possibility of hitting the target.
And an additional follow-up, have you found that the directionality capability of modern leads to be particularly helpful in targeting ANT or other nuclei? Or do you, for ANT in particular, do you tend to just use them as a ring?
Well, only when the surgeon misses, which I'm sure you never do.
Of course, never.
Then we point it.
Yeah, we don't tend to use directionality.
Yeah, neither do we. I will point out, just in answer to the previous question, we did a little study of is more better in RNS in the hippocampus. And in cases where we had a unilateral onset rather than doing bilateral because there was no reason, we put two electrodes into the hippocampus, trying to cover more of it. And maybe a little bit naive, but that was the idea. And it turned out that was more effective, but not because we had more electrodes or more contacts. It was because then we were more likely to have a contact in the uncus, which turned out to be the most important area, like it is in most laser ablations and in some other studies as well. Again, this is a stereotactic operation, and usually, whether it's movement disorders or depression or epilepsy, it comes down to having one contact in the right spot.
Awesome. I wanted to shift gears to the following question and maybe open up for a few minutes for a broader question for the group about the role of stereo EEG in helping to identify potential targets and plan or even select whether you're going to use open or closed loop neuromodulation. I guess my first question is, how in general is that used at your centers or in your practices about do you prospectively are you starting to prospectively implant thalamic nuclei to investigate how they're involved in seizure networks or no?
You want to go first, Brian?
Yeah, we do. We tend to, in patients where we think neurostimulation might be a potential outcome for the patient, we do try to think about which nucleus might be of interest for stimulation and then implant that. And then for many of these patients, they also would receive some temporary trial stimulation during the implant to get some sense of effectiveness.
Can't prove it, but it seems obvious to me that if a temporal lobe seizure is not propagating through our ANT electrodes or only gets there very late, then that's probably not the best node on the seizure network to stimulate. But each time we submit a paper on measuring something from what Dr. Butch has coined multinodal stimulation, at least one of the reviewers asks, what's the evidence that this makes a difference? And we don't have it yet.
I think it's pretty ubiquitous at this point. There was a lot of hand-wringing about whether it's acceptable. Some people use the approach you described where you simply extend your electrode. I don't believe that's really a thing. Like my electrodes, when I put them in and then I say, okay, now what would happen if I extended them? They don't end up in the places where I want to record from. So
You have to
I
change the trajectory.
well, that's your point. You have to change the trajectory, so it's kind of a smokescreen. So yes, we say we are specifically trying to record from this, that, and the other thalamic structure, and so we're going to specifically target it, whether it's with an electrode that gets there through some hook or crook, or whether it's with a dedicated. ANT is pretty easy because you can go through the cingulate. You can get cingulate, anterior cingulate, and get ANT. Um, pulvinar, if you're thinking about parietal occipital, then you're probably going to be in that zone anyway. VIM, you're going through the motor. It's reasonable to do it
You
for
can get
for
bilateral
efficient.
C. You can get bilateral CM if you go through the massa intermedia, which we do.
Yeah.
So actually, speaking of, Dr. Gross, am I correct in interpreting your comment as saying that your ANT stereo EG electrodes go like this through the cingulum? Mine and I think Dr. Fisher at Stanford, I think you described ones that go through more orthogonally, kind of through the insula and then extend beyond.
Not
I,
the
I, I wish Dr. Butch was here because he should talk about this, but I think he's modified. It's an anterolateral approach. It's not a
right.
orthogonal approach.
Yeah.
Understood. So we had a question from the group I think is very interesting is to what extent do you think that introduces a little bit of a sampling bias in the stereo EG in the phase two, where you may be kind of missing the most effective area of the ANT because you're implanting it in a non in a way that you wouldn't ordinarily implant the ANT in your final DBS electrode, and so maybe you're picking up more seizures from the pulvinar relative to the ANT, but it's simply because you're you're not targeting it as effectively as you might otherwise do so. I don't know if you have comments on or thoughts on that.
I will say that's a very good question, and it's the first time I've been provoked to think about it, so I'll think about it some more. But with the anterior lateral approach, we almost always get at least two in the 0.5 millimeter spacing. We almost always get at least two contacts in ANT if everything goes correctly.
And I would say the sampling bias actually comes not necessarily from taking a different approach, but from the fact that stereo EEG is not the most stereotactically accurate way to implant the thalamus. These electrodes last see a stereotactic tube at the surface of the brain, and they are very flexible. And if we were putting in a DBS, we would never do it in such a manner. So we put them in, and we may even call them ANT nuclear electrodes, but they may or may not be where we really want them to be. And that the pulvinar, of course, is very large, but then there's subnuclei, and I haven't seen anybody define, on imaging whether it's in this subnucleus or that subnucleus. That's a templating type of thing. So I think that comes down to the inaccuracy of putting in the electrodes with stereo EEG.
In pulvinar, though, can't you tell medial from lateral? I mean, we actually usually
Yeah,
have
medial from
contacts in
lateral,
both.
but there's four nuclei at least.
I
So
know, inferior, lateral, medial, but just we want to make sure that if we're treating temporal lobe epilepsy, limbic epilepsy, we want to be in medial pulvinar. If we have the rare case of parieto-occipital, then inferior or lateral may be the best target.
But I think the inaccuracy, as you mentioned, Dr. Gross, is really important, and especially because the contact spacing may be wider than what
it
you.
is.
Yeah, 3.5
Yeah.
millimeters may not be what you actually want, and hence the previous question.
Correct. Yeah.
Awesome. Maybe one last question, Dr. Lundstrom. You mentioned at the end of your talk a note about safety and efficacy in a pediatric population. You mentioned a bowstringing, which I think is referring to, the IPG at the or the wire at the neck. Have you ever had a case where because of skull and brain growth, the electrodes, pulled out of their intended nucleus? Is that something we have to worry about when implanting young kids or not?
I would have to ask one of my pediatric neurosurgeon to colleagues to see what they're, not to my recollection. Usually it can get tight here, and then you have to maybe loosen up some things down here. But hopefully things are tight enough up here. I remember one case in a pediatric patient where that was an issue, but then I think the question was it actually secured up here the way it should have been?
Just a quick perspective on that. The wire is not the limiting problem. The bowstringing doesn't come from the wire, it comes from the scar. And then the scar can attach to the electrode. And that's why it pulls out. And there's really no way to get around that except for cutting the scar itself, which we do. We will go in and make 3 or 4 or 5 cuts. But it is a problem with kids when they get older, and even with adults. I mean, the longer they're in, the more likely there's going to be something that's going to adversely affect the electrodes.
And I don't know if you found it may be related. Kids may have a slight increased propensity to play with it a little bit. Some adults do too, but
Twiddling.
Twiddler phenomena, yeah.
Yeah. Great. So we're about 20 minutes over, so I don't want to keep our speakers too much beyond their allocated time. But Shrona, did you have any last comments you wanted to end with?
Sure. I just really wanted to thank you all for just a truly, absolutely fantastic session. Thank you so much to our speakers for sharing your tremendous wisdom with us. Thank you to our moderator, Dr. Khanna. And really thank you to our audience for sharing your evening with us. Our next session in this series, the epilepsy surgery series, will be part 4, which will really focus on resective and ablative techniques. That'll take place on September 9th, the same time as this session. And we hope to see you all there. And with that, good night to everyone.